just where he pointed, his symptoms, the way it happened. Obviously, there might be more questions I would ask this athlete just to make sure it wasn't anything else. But what do you think it is? Have you taken a basic injury class? I'm sure you have. Right? Any ideas? And it's your deltoid. It could be a deltoid. Just because why? What tells you that?
What is it? The injury mechanism.
Yeah. So that's a good indices of suspicion. What's on them? So we're going to collect these indices, line them up, and then we're going to rule out one at a time to kind of narrow down what we think it is. Or you can do the other way. Based on what he told me, I have an idea of what it is already. Any ideas? Could be deltoid. Not bad. So we didn't even ask him about range of motion. So we could have asked, okay, active range of motion, which ones were painful, which ones were weak. Passive range of motion, which was painful. Resisted range of motion, which was painful, which was weak. How much range of motion does the person have with all these? What do the accessory movements look like? We could have done all that, but we'll get to that later. So medial deltoid.
Pinched nerve.
Pinched nerve, possibly. Shooting pain on the outside. He said it was a little bit weak. Yeah. A little bit weakness. Injuries that present as weakness. What muscles involve strength in that area? That's something to consider as well. So, any other ideas?
Don't you have like a muscle that in your big toe that actually like starts on your big toe, but then it runs underneath your foot? Malleolus comes up behind the sun.
Starts on your big toe. How is this from? Goes up the medial side on the left side. Yeah, it could be a muscle issue. Say muscle damage, possibly. So I thought it was a high ankle sprain. From what he said, I asked you and you didn't put your hand up. So high ankle sprain was what I was thinking. But we'd have to rule out these other things, and the way you rule that out is we do strength testing for the muscle stuff. You said deltoid. You tailor tilt for the deltoid. Rule those two out. If it's not, then maybe high ankle sprain, treat it as such. If it doesn't get better, recess. But that's what I was thinking, and that was just after a 2-minute conversation. Obviously, it wasn't good assessment, but it was just something that jumped out at me right away. So that was me trying to do this. Okay, I just got a bunch of information. I thought it was that. So anyways, those are different types of clinical reasoning skills that will come into play. Where you are is going to be on a spectrum. Okay, some people are going to start with this, and that's fine, because you need to, again, learn the pieces first, put it all together, and then with practice, everything will just flow nicely. Okay? Just a side note, Jeff Norman, he's at McMaster. He has big research in medical education, specifically problem-based learning. How many of you guys have heard of problem-based learning? It's a good way to learn. We just give you case studies, you work on it on your own, essentially. So those are some basic principles. Now, again, what our goal is, CAT exam, you need to pass that exam. Okay, so when you practice all today, tomorrow, and all the labs that we do, these are just some reminders. Okay, and you need to be comfortable with that, because we don't want your verbalization to make you nervous during any exams. We want you to be comfortable just thinking out loud. Okay? So verbal communication, again, beware of your toe. Nonverbal communication, your posture, touching, facial expressions. And I say touching for a reason, because there are some areas of the body that are sensitive for people. And I'm not just talking about the junk. I'm talking about everywhere. I had a patient who was this big. He looked really dominant. He kind of scared me when I first met him. But he was really jumpy. Anywhere on his back, between his shoulder blades, by his traps, and I don't know why. We never got to that conversation yet. But I think there might have been some other things going on in his past that he was so jumpy. But every time I had to touch him, I had to warn him. So you have to ask permission. Don't just and start doing stuff. Just tap them on the shoulder. Hey, so I just look at my hands on your hip. Is that okay? She looks scared. I was like, we'll do a couple of things first then. But you have to establish that relationship at the beginning. Okay, when you first meet them. We'll talk about starters. What you do when you first meet the person. We kind of touched on it yesterday a little bit, but But you need to be aware of that. Okay? Think out loud. State what you actually see. Now, this is contrary to what you did in EMR. Because I think in EMR, typically what you do is, I would do this, I would do that. What do I find? What's my heart rate? Like that type of thing. So for today and tomorrow, we're going to ask you to look at your patient, or another patient, or another patient, or another patient, and say what you actually see on them. If you do that on the CAT exam, and whatever asymmetry you find is not part of the exam, they will state what you find is normal. But just move on. Okay? So if you see that an anterior superior iliac spine is a little bit lower on the one side versus the other, state that. That's what we want you to do. Don't fake it. If you're not sure, who cares? Trust yourself. State what you don't see if it's based on your history. So you said that you heard a pop, but I don't see any swelling or redness, because that's what you would expect for an acute injury. So that's the other thing we're expecting you to say as well. We will have lists of landmarks and things to look at and so on and so forth. Yeah, you can memorize that as well. But I've seen this. You're looking at someone, or your face is looking that way, but your eyes are over here, imagining that same list, and you're reading off that list over here. And you're not even looking at the patient. I've seen that before. You are assessing a person that's in front of you. So assess them. You are not wrong if you say, I think that person's left foot is flatter than the other. That's not wrong. That's your opinion. And that's fine. Okay, so trust your eyes. So, state what you actually see. And if you think, again, based on your history, it's a particular injury, and you're expecting to see something because of that injury, then state that it's not there if it's not there. Okay? So let's say, for example, the person just took their Zimmer split. You guys know what a Zimmer split is? It's a big Velcro sleeve that has, and they usually put that on if you go to the emergency room and have like an ACL or big ligament sprain. They just throw it on everybody with knee injury, actually. It's pretty rudimentary. Anyways, let's just say that someone just took that off and they're limping and their kneecap's like up there, and the whole history says dislocated kneecap, and you say, I'm looking at the kneecaps are symmetry and da-da-da. I'm like, it's not. It's off to the side. Okay? If the person did, if you did suspect it was dislocation and that's what you were expecting to see, but the kneecap is in place, then say, there is no deformity with the kneecap. The kneecap's normal. It's not off to the side, it actually went back in. Okay. So the more you talk, the better. And like I said before, if you're being examined by your supervisor, by me, at the CHA exam, a lot of times their heads are where? Their eyes are where? Examiners. Where are their eyes? They're usually down on the paper. Okay, so make sure you say it so that we can give you that little check to say that you did it. Okay? Okay, so starters. Again, every time you meet a new patient, just introduce yourself. When you're working with your teams, introduce yourself to the coach. For STS, we're not going to, I think you got the email, we're not going to introduce you to the coach initially when you get to the schools. Go to the principal. And the principal will introduce you to the high school sport medicine teachers and then the coaches. And that way everybody knows you and everybody gets comfortable with you. Same thing should happen at the other sites. So you've already met your supervisors, I'm hoping it was a good impression, the initial one. Now you've met your teams, you've met your athletes. Again, introduce yourself. I was actually out with a buddy last Saturday. We went to Denny's at 3 p.m. Or 3 a.m. Don't ask me what I was doing at 3 a.m. But we went to Denny's after. We walk in. He's the nicest guy ever. I play basketball with him all the time. He actually works at the Aboriginal Center. So we went out and we're at Denny's, and I had never seen this before. But the waiter comes over and he's like, "How many?" We're on the table for two, and we start. And he goes, "Oh, come right this way." I'm like, "Thanks." And my buddy goes, "Thanks, Alex." I'm like, "How do you know that guy?" He's like, "No, I just read his name tag." I was like, "Oh." And then as soon as he came over and started taking our order, it is automatic at first name basis. He ended up sitting down with us. We had a conversation. I've never seen that before. It's actually pretty funny to do. It's actually pretty cool. Alex was a cool guy. Anyway, building relationships, fun times. Patient comfort. If this goes well, they will be comfortable. Touch me, let me do whatever you want to me, help me get better. Once that door is open, you can walk through and anything is possible. So you need to establish that, make them comfortable, make them trust you. What to expect? One way to make them comfortable, just go through the process with them. Just tell them this is what I'm going to do. First, I ask some questions. I'll probably ask to take your shirt off because it's shoulder, and you're going to have to take a look at it. And then I'll have you just do some movements, and I'll push on your shoulder a little bit. It might be a little bit uncomfortable, but we'll ice you afterwards, and we'll just try to figure out so we can get together and put together a reasonable rehab plan for you. Is that okay? Or do you have any questions before we begin? So that way you don't surprise them, when you start touching their butt and stuff like that. Okay, so explain what you'll be doing with them so they're not caught off guard. Again, nonverbal communication is important. And last but not least, get consent. Is this okay? Are you going to be fine with this? And sometimes people will say no. Sometimes people might say no. I can't remember if I told you guys, but there is a at the med school now they've implemented what's called it's an MMI, I forget what the letters stand for, but it's something mini interview, multiple mini interview. It's an admissions test, if you will. So they're not, so at med school they don't take your GPA, they don't take your MCAT scores only. They put you through scenarios to see how you would react. And a lot of it does not have to do with your skills. A lot of it has to do with this. So the one scenario we actually watched in class, it was a Muslim woman. She was an actress, but covered from head to toe. She just saw her eyes, and she walked in. She had abdominal pain. She went into the emergency room, where this emergency room student or physician student, medical student, was told that you need to assess this person because she just walked in. And anytime he tried to assess her, she said, "You can't touch me." And then he went off and, "Well, I need to take a look at your abdomen if that's what you're complaining about." And he almost started fighting with her. What do you think that did? Was the door open? In fact, she put a couple deadbolts on that bad boy, and she did not let him do a thing. He did not do well at that station. It doesn't matter how good skill-wise you are, if the patient doesn't trust you, it's not going to work. Okay? Ask them if it's okay. We'll talk about, when we do conflict management, we'll talk about different strategies to handle that particular situation, because again, you might come across that. Informed consent, generally what and why, how, risks, impacts. So these are the types of things you do have to do to get implied consent. Again, if you don't get it, you can't proceed. Just refer them to somebody else. If they're not comfortable with you, just say, well, maybe I can find somebody else that could help you. On most assessment forms, there is a line, a signature line, that gives you consent to assess them. On the assessment forms that Janelle will have you create, do not forget that section. Okay. She'll talk more about those assessment forms, I think, in her class. Okay, so medical documentation. Over the last 10 years, this is what I've seen. Everyone's handwriting gets terrible. It has been getting terrible. Okay? It's just the nature of how technology progresses. Everyone's texting. But it needs to be done. There's some places where you eventually work where they have everything online and you type. But there's still a lot of places where you have to literally handwrite a lot of your documents. So take your time. Because if you can't understand your own writing 5-10 years from now, you will get burned. Okay? You could get sued. But you need to be able to interpret what you wrote 5-10 years ago. And if you can't even read it, think about someone else who's trying to read it. It's a legal requirement. It's a means of communication. It needs to be clear. It needs to be detailed. It needs to express everything you're thinking about. It needs to be organized. It's meant for billing. It's an objective review of progress. So we'll talk about SOAP notes in a second. But remember how I said assessment is an ongoing process. There is a template that you use to capture that ongoing assessment, and it needs to be done, and it needs to be followed. Sometimes this information can be used for research data, but again, that's like consent forms and blah, blah. But it can also be used to improve and maintain quality of care. So if I read somebody's notes and I realize that they've missed one key component of rehab, I'll throw that component in because I was able to catch that. A lot of times we'll trade patients in the clinic. It's not the most ideal situation. People have to go on vacation or something happens, and you have to take somebody's patient. So you need a detailed list of what that person was doing. And if they missed something that you caught, then throw it in there. But you're not going to know that unless that person did fantastic notes. So you guys have to keep fantastic notes as well. Make sure it's legible, permanent. Do not do anything in pencil. This is not good and it's not professional. In some places, they will even tell you it must be blue ink. Must be blue ink. Do not use red. Do not use pencils. And do not use any other sparkly colors. It is a legal document. It needs to be accurate as possible. Chronological. Everything is always dated. If things happen, if two separate occasions happen on one day, put a time as well. Abbreviations. Now, in most medical textbooks, including McGee, there's actually a dictionary that has shorthand for a lot of commonly used medical terms. It's good to be familiar with that. Don't just start making up your own, because it might be misinterpreted. Okay. Error, correction, and blank spaces. There should be very little blank spaces. Why? Why do you want to minimize blank spaces? You don't want people to add stuff to your notes. If people do that, they're just trying to screw you over, potentially. Okay. For corrections, one line through, initial. Okay. You have to sign it to make sure initial, and it's strictly confidential. Do not share these with anybody. You will get in trouble by getting kicked out of the program. That is patient information. When you do your logbooks, I do not want names. My player is fine. My athlete, my patient. Don't give me names. I don't need names. Anything that can identify your patients, get rid of. In this documentation, you need that. But you need to be aware that you cannot share that verbally or written. You can't share that with anybody. If you're a patient and someone was sharing your information, you wouldn't like it either. SOAP notes. Any idea what SOAP stands for? S. O. A. And P. Time. Have you ever heard of HOPS? What does HOP stand for? H. O. P. S. Fantastic. How does that fit in with SOAP? History. Observations, palpations, special tests. That's your objective examination. Analysis or assessment. That's your differential diagnosis. Plan is your treatment. That's kind of how it interrelates, if you will. Okay? So we will do this so that we can figure out this, so I can teach you and show you how to do that. Sound good? These are Janelle's SOAP notes. Dated, subjective, objective examination, analysis and or what you did, and then plan for next time. But there's an ongoing assessment. Under objective, that's your objective examination. It's still part of your assessment. You need to do this to figure out what you need to do here. Based on how this turns out, put a plan in place for next time, just in case somebody else takes this patient. They can read that last line. Who did this? Janelle McAllister, certified athletic therapist. Okay. Any questions? 10-minute break.